Good morning, all of you. Myself, Dr. Prashant Vidate, junior resident of ENT. My study is regarding a study of socio-demographic pattern, cause of injuries, structures injured, and management done in all the cutthroat injuries in a tertiary care hospital. Cutthroat injuries are one of the most challenging emergencies encountered in our day-to-day clinical practice, as per ENT is concerned. The larynx, trachea, pharynx, carotids, and nerves are located in this vulnerable zone. Prompt airway management, bleeding control, blood transfusion, and timely surgical repair are very crucial. Delayed treatment can result in asphyxia or hemorrhage, leading to death. What are aims and objectives? To analyze the socio-demographic pattern, causes of injuries, affected structures, and management approaches in all cases of cutthroat injuries presented at our tertiary care hospital. What material and methods we used? Actually, we analyzed 38 cases of cutthroat injuries which were presented at our ENT department in casualty from September 2022 to September 2024. And it included all the age groups, genders, socioeconomic status people. Exclusion were all the head injury patients and unconscious patients. Patient details including demographics, socioeconomic status, which is we classified under modified Kuppuswamy scale. Causes, injury mechanism, damage structures, treatment were documented. Complete history was taken and thorough physical examination was done. Clinical findings, imaging, blood investigations were reviewed. Data confidentiality was maintained. Patient underwent prompt management as per ATLS guidelines. And investigations were done. And what are the crisp results that we got? In this study, 89.47%, that is 34 were male, 4 were female, with most commonly affected age group being 21 to 40 years. Now we'll talk about why the 21 to 40 years age group was affected. Majority of patients, that is 41%, were from upper lower socioeconomic status. Most common cause of cutthroat injuries were homicide, followed by suicide and accidental. The sex distribution of patients were mainly males, that is 30 out of 38, 34 were males, which comprise 89.47%, followed by, that is females, just 10.43%. The age distribution that we are talking about is the age group of 20 to 40, in which 20 were male and 1 was female. Like this age group is most commonly affected, whereas the other, followed by the age group 40 to 60 years. Whereas other age groups are not that affected, and it is also seen in previous studies. The mode of injury was always maximum time, as we have observed, it was homicide only. Because of the unemployment, because of the aggressive nature of males, etc. Like these different reasons provoked the mode of injury to be homicide, followed by suicide and accidental. As day to day, the suicide incidence rate is also increasing, and this everything is shown in coming studies. Like in previous studies, we have seen, and in coming studies also, the suicide rate is continuously increasing. Maximum injuries were done with agriculture tools, as like maximum people of India are residing in villages, so it is very accessible to get the agriculture tools. Whereas kitchen knives, that is agriculture tools, that 56% were done by agriculture tools. Kitchen knives, that 25%. Followed by blade, which is 15%, and axe, that is 4%. Injury of structures of the neck. According to Roon and Christensen's classification of anatomic zone of neck, the zone, that is zone 1, that is from the level of clavicle to the inferior border of cricoid, that is zone 1, in which 27% of cases injuries that we have recorded, and zone 2, that is from inferior border of cricoid to the angle of mandible. That is from 49% cases were involved. And zone 3, that is from angle of mandible to the base of skull, that is zone 3, that is 34% cases were affected. What that is from zone 1 and zone 3, it is mostly surrounded by bones. So they are not commonly affected. But whereas zone 2, which is exposed, like we can see outside, it is very easy and accessible in homicidal and suicidal injuries. So zone 2 is most commonly affected. In maximum, in 100% cases, like skin, soft tissue, small vessels were affected. Whereas the important structures were not that affected, because as the intensity of injury was increasing, the greater important structures were affected. Distribution of patient according to treatment provided. Like in our 38 cases, just simple wound closure was enough in 29% of cases, and proper counseling was done with the help of psychiatrist. Whereas in 9% cases, we did tracheostomy, we admitted the patient, and we kept a follow-up. Discussion. The male predominance observed in the study aligns with findings by Onoto Low et al. And Manilal et al., likely due to risk-taking behaviors and higher involvement in interpersonal violence. Most patients in the study were of lower socioeconomic backgrounds. Agriculture implements were the most common weapons used, with homicide being the leading cause of neck injuries, consistent with findings by Panchappa S. et al. And Gordon O. et al. In this present study, simple wound closure and tracheostomy were the most commonly treatment provided. Research by Azanello BC et al. And Akapan L. et al. Also displayed the importance of tracheostomy in the treatment of patients with neck injuries. Most common presentation in the study was open lacerated wounds with hemorrhage, similar to findings by Onoto, Low, and Manilal et al. Major causes of death were hypopharyngeal, laryngeal damage, and active bleeding, leading to shock and asphyxia. In this study, psychiatric illness accounted for over 50% of cases, consistent with findings by Mohanty S. and Tera JL et al. Psychiatric conditions are recognized as the strongest predictors of suicide. So, as we have discussed, psychiatric counseling is very important after the treatment of tracheostomy, means after the treatment of cut throat injuries. Proper follow-up should be done. And these neck injuries require a multidisciplinary approach involving an anesthetist, psychiatrist, and otolaryngologist. Early presentation and prompt care improve prognosis. As the patient is not reaching in time, we can't save the patient. As the complication will increase, patient will be in shock and asphyxia, and there will be not a good prognosis. Incidences of self-inflicted neck injuries were more frequent among young males, often linked to psychiatric illness, unemployment, and poor socioeconomic conditions, which significantly impact mental health. Homicidal injuries are often linked to low socioeconomic status and can be reduced by addressing societal issues such as poverty, unemployment, and drug addiction. If these factors and proper counseling is done, then maximum suicidal injuries can be prevented, whereas homicidal injuries can also be prevented. Enhancing communication systems, first aid awareness, and ambulance services can significantly reduce complication and mortality in such cases. These are my references. Thank you.
You have done 38 cases.
Yes.
Okay. So in these cases, you mentioned 24% cases, 9 cases you need tracheostomy.
Yes.
So in your study, how much was the average duration of tracheostomy? For how many days you have kept this tracheostomy?
Sir, actually, first for around 5 to 7 days, we were keeping that patient on Potex, and after that, if the patient is responding well, then we are shifting it to metallic, and we are observing for 2 to 3 days. And also it will depend upon the injury which is just above the tracheostomy site. So around 10 to 15 days was the enough time.
Okay. You mentioned the injuries like level 1 or zone 1, zone 2.
Yes.
How many cases you got any carotid or something injury like a major vessel injury?
Major vessel injuries like sir around 1 case we got it.
Okay.
Yes.
Okay. Okay.
Yes,
sir.
Thank you, sir.
Okay. Thank you.
Have you came across any case after the trauma that has been with the stenosis component because of the tracheostomy or because of the injury? And if that, have you managed such case?
Sir, actually we got one tracheal stenosis case.
Okay, so
And
the level of stenosis is?
Tracheal stenosis case we have got. And but it wasn't that means patient wasn't having that much of symptoms. Like we have done endoscopy. Patient was not but asphyxic or not that breathlessness was there, but
So
he was.
how you get to know that the patient was having the tracheal stenosis if there is, he was unsymptomatic?
Patient came with continuous he was having some breathlessness issues. He was having respiratory discomfort was there, so he came.
So if it's a respiratory discomfort or it's a noisy breathing, because that differentiate between a mild to severe grading.
No, sir. Actually, discomfort was there, not noisy breathing wasn't there. Sir.
Okay. So treatment?
Treatment, sir, we have given actually that to be true, we have referred that patient as our department is not. Thank you.
In fact, he was supposed to ask you in how many cases you required a prolonged decannulation? That is what you want to ask. That was his question. So in such cases where you get subglottic stenosis, you cannot decannulate the patient. That was his. Okay. Sure. Thank you.